Okay, good afternoon, everyone. Thank you for coming up here for my internship presentation. My name is Saba. And so for my internship, which is a mandatory part of the BMHI program, I work with the Australian Institute of Health Innovation, which is a leading research institution located in Sydney, Australia. It's primarily housed in the Macquarie University, and it has 3 centers. So there is Center for Healthcare Resilience and Implementation Science, and Center for Health Informatics and Health Systems and Safety Research. Within these centers, they have different teams that work on different areas of research. I worked for 10 weeks with Center for Health Informatics. So my team was called Patient Safety Informatics. So we worked on different projects that had to do with consumer safety or patient safety. So my project is called Safe Health Apps, and about safety concerns of mobile health apps, the apps that were being used by consumers and not the providers. So we're talking about users of apps. Okay, before we go into the nitty-gritty of the project and its objectives and stuff, let's meet this girl. She's Asher. She's a young girl from Kenya. She sells water on the roads to earn some money, and she comes from the kind of community where girls and women are 3 times less likely to buy a phone for themselves. Instead, they are gifted the phone. So you can see how luxurious of a thing it is for them. And so all other teenage girls, when she got hold of a smartphone, she was super excited and she wanted to check out everything that was there. So she came across this app that misdiagnosed her with HIV. And the app did that by just analyzing her fingertips. For her, now you can imagine the kind of community she belongs to. It was a trauma. It wasn't just an error. It brought to her socioeconomic and psychological and emotional trauma. And so the researcher who was working in that area, she said that she wasn't the only one. There were more victims to health apps. And these were the few who spoke about it, which means there were more who didn't come out. So that makes it super important for us to look at how mobile health apps that are supposed to be beneficial for the consumers actually are giving more harm, right? So that is what the project is all about. Let's take a couple of minutes and look at what Food and Drug Administration has to say about health apps. FDA divides health apps into 3 categories. The first is medical devices, which is the most complex ones, and these are the apps that announce themselves with claims to be medical devices. These are diagnostic in nature. These are prescriptive in nature. And then there's this other category called wellness apps. These are low-class apps that only are there to educate consumers. They can track your activities. They can be your reminders, but they do not diagnose or prescribe medicine. Now, there is this interesting category in the middle. It's called intermediate. So these are the apps that fall nowhere. So they're not medical devices. They're neither wellness. They're a combination of both. So these will be devices that will be helping you be aware of things, but at the same time will help you diagnose yourself. Okay, now talking about mobile apps. Right now there are a lot of apps available on leading markets. If you look at the graph on your right, these are the leading app stores and the number of apps available. And this was the data from 2015. By the end of 2017, there were approximately 325,000 health applications available on iOS and Android. That's a huge number. And this is rising because the number of consumers is increasing too. So more people, more apps, more people. Now the problem is, even though we have so many apps and the number of apps is increasing day by day, but these apps are not being regulated or monitored or even built on a safety standard. Also, there is a very limited examination of the safety concerns related to these apps. So the project Safe Health Apps did 2 things. We started with a scoping review of literature, and then we went on with a quantitative survey, the purpose of which was to analyze the safety reports from consumers themselves. Both of these methods were based on categorization of safety concerns and then the classification of consequences. So what were the safety concerns, and then what happened because of those concerns? To classify the consequences, we used already established criteria. So it's a 5-category scale. Starts with actual or potential harm. This is like a clinical consequence where something adverse happened. Goes on to near miss, a noticeable consequence but no harm. There could be a safety concern that has no noticeable consequence, or a hazardous event. A hazardous event is important to understand because it's like a problem that could eventually lead to an adverse event. So this is the scale that we use, and you'll be seeing this coming up in later slides. So the first thing, objective, the scope and review. So it was simple. It was about reviewing studies related to health acts and identify the safety concerns and the consequences. There were 4 inclusion criteria. We looked at literature published from 2013 onwards, and this was conducted in June last year. So we had good 5 years data with us. They had to have app that was consumer featuring and not the provider facing. Then the study design was systematic reviews or RCTs or analyses of apps or a pilot test. Also, it was important for us to make it into our study to be talking about safety risk or adverse event. We started with 1,952 studies, and after thorough screening, we were left with 48. So you could see the reasons for exclusion on both ends. So in the end, we reviewed 48 studies. Out of those 48 studies, 42 were some kind of app reviews. So they were either doing like app in silo or groups of apps, say cancer-related apps or age-related apps and things like that. The range of sample size includes both apps and users. So there were somewhere between 2 and 750 apps in each study, and 1 to 1,932 users that were a part of that particular study. Now the types that we talked about earlier. So immediate was the highest occurring number of apps that was studied. We also looked at the consumer engagement functionality. So this is about how does app engage the consumers. So these are like 7 levels of consumer engagement, and we said that most of the apps helps in displaying and summarizing user engine information. And then it goes up to engagement levels. Some may track your information, some may provide guidance. And the highest level of consumer engagement functionality is rewarding behavior change. So for example, in your activity trackers, they offer you medals or like cups and stuff like that. So that's rewarding behavior change. So most of the studies, like I said, displayed and summarized the data. Okay. So frequently reported concerns that we found in our scope and review, the most frequently reported was absence or lack of sufficient scientific evidence. So there were lots of information, but those information were not really evident enough. Then there were studies that reported incorrect or incomplete information. Then we had diagnostic or calculation error. So there were studies about melanoma detection apps where you send the picture of your skin rash to the app, and then the app will tell you if it's malignant or not. These kind of like diagnostic issues. And then there were variations in content quality. So say cancer app A would say one thing, when cancer app B would say a totally opposite thing. So it was kind of variation in even similar groups of apps. And then there was lack of medical professional involvement. I think we all know that, right? Because when apps come into the market, it's usually the IT people or app developers who are doing this, and not really the medical professionals. Other than those 5, there were apps that were inducing unintended negative harms. So, for example, a study reported that a group of apps that was actually supposed to help you reduce your alcohol consumption was actually encouraging you to drink more by their competitive gains. So like, okay, if you drink more, you get a medal. So kind of like inducing negative harms. Then there are lack of regulatory evidence. Like we said, FDA only regulates the medical devices, and it is not right now regulating any other kind. One study also reported that apps were actually provoking anxiety. So this was about a group of apps that were directed to pre-op patients. So a patient who was to undergo surgery was supposed to log into this app, but they found out that actually the information that the app contained was provoking anxiety instead of calming them down. Apps were also found to have insufficient scope, so they were not dealing with all kinds of information related to one area, and then there were inappropriate response to consumers' needs. So, for example, certain psychological apps, when you tell them that you are feeling suicidal, they won't do anything. It's nothing at all. Okay, now there were 22 studies out of 48 that also talked about adverse outcomes for the consequences. So actually were 5, for example, increased alcohol consumption already talked about, and then there were some noticeable consequences, but no harm. So for example, activity trackers were found to be not recording the steps correctly. So this didn't really harm people, but there was a safety concern. And then there were 3 hazardous events reported. For example, those diagnostic apps, there is a chance that people would believe on that app instead of going to a physician to get medical help. So that's a hazardous event and can cause adverse outcomes. Okay. Then we saw the relation between consequences and functionality. And we found that those apps that were either reminding or alerting patients had more safety concerns. So that's kind of this graph is important to see because it tells you how patient engagement level can actually be harmful, or how careful one has to be while developing an app to ensure that the more you engage your consumer, the more safe you have to be. Yeah, that was part 1, the scoping review. This is our part 2, which was safety report analysis. So we created this survey and we asked consumers of health apps to fill those surveys and report any kind of safety concerns that they have experienced. This was conducted between August last year and it ended in November. It was consumers, they themselves reported safety concerns via an online survey. These were consenting adults 18 and above. They were the actual mHealth users. It was from Macquarie University itself, so the survey was advertised there and we got responses from there. It was an online survey that had 5 components. It talked about health apps. It will ask you what kind of health app are you using, the purpose of use, why did you use that app, and then how did the app respond to your problem, what happened, was there any consequence, was there any adverse outcome, and then the responder was demographics. The analysis did the same thing like we did in scoping review. So we looked at safety concerns and the consequences. So we had 162 participants for our study. The female to male ratio was quite high, so we had more females than males. And this was actually one of our limitations too. Majority of people were between 25 to 34 years, and 76% were using somewhere between 1 to 3 apps. 65 participants reported some form of safety concerns, and total concerns reported were 86. Now, this is the purpose for which consumers usually use apps. So you see the highest number goes to weight loss. This is most commonly reported purpose. And then we have, it's very similar, like what do I eat? So keep a check on my calorie count. Very similar to weight loss. So people use apps for these reasons. Only one person said that they use the app to check with their doctor or healthcare professional. Maybe because most of the apps do not really offer this feature. So the 2 most frequently reported concerns from consumers were errors in information tracking. It was similar to what we saw in the scoping review. So activity trackers won't count my step correctly, calorie counter is not giving me the right recommendation, and incorrect or incomplete information. So there was this interesting thing. I have some form of bone issue, and so the app should tell me how should I exercise. Like the app only tells me to exercise, but how do I do it? It's not there anywhere. So it's an incomplete information, right? And it could eventually be harmful. Other safety concerns were insufficient scope. So because this survey was done in Australia, a lot of people reported that the apps had American metric system. And so it'll tell you in pounds and not in kg and like that. So it's like, also there was this one respondent who said that he had dwarfism. And so all the apps only talk about normal measurements and nobody takes care of the dairy population. There were complex and demotivating interface. People reported inability to interact with other devices. So these days it's very important. I have my mobile phone, I have my laptop, I am wearing Fitbit, I want to see same thing everywhere. And interaction is a problem. There were inappropriate alerts, which is kind of funny because you want us to tell us, like remind us things, but when it starts to do it inappropriately, that's kind of not good. Addictive in nature, okay, this is something that I can agree with. Some apps are like super addictive and you cannot let them go. People found that their informations were lost. There were errors in calculation. One of the participants said that she was using an app for her diabetes, and a couple of times her app gave out wrong dose of insulin calculation, and one time she was admitted because she went into hyperglycemia. That's like so dangerous. So actual or potential harm. We had 12 respondents telling us that they had actual harm. So there was undesired weight loss because the calorie counter wasn't appropriate. So the person lost weight that they didn't want to. There was a sprain injury reported, over and under eating. People missed their dose of drugs. So these all harms are categorized as minimum harm. We looked at another established literature that talks about categories of harm. So these all harms fall under minimum harm. There was some nearness, for example, confusion in calorie requirements. So people ended up eating wrong food, but they didn't. They looked at Google and they found out, okay, this is the right thing. The app is telling me the wrong thing. So that was nearness. There was some noticeable consequences and hazardous events. So inaccurate sleep tracking, while it didn't really harm the person, but it still has the potential to do it. And then there were consequences reported that were not really noticeable. So what did consumers do? Now we asked them, okay, you faced this adverse event. What did you do? So 70% of the participants said that they contacted a national authority. We tried contacting their national authority to see what they did, but unfortunately we couldn't get the response. And then 24 participants, which is 37%, they discontinued using the app. And if you look at this number, 37% is nothing, which means other almost 70% are still using the app, even though they know that there are concerns. Self-reporting was our biggest limitation. So because we were not like there witnessing when the harm happened, it was more dependent on the self-reporting. And it was also limited to a university setting where female. So to conclude, like we started with this bird story that told us that safety concern is such a big issue these days, and with the number of apps growing up, it is really the right time now that the regulators and the policymakers take actions to improve the safety of apps. Incorrect or incomplete information was the commonly reported problem in both the methods, both the consumer reports and the scoping review. So this says a lot. It's important that if the apps are giving our information is correct and complete. There is a need to address gaps. We have to have a regulatory framework, so not all apps should be out there in the market without being regulated first. Healthcare professionals, and I think our program BMHI is kind of an example where we integrate informatics with the healthcare. So this is what is needed in the industry. App development needs healthcare professionals to be part of it. And recency check. So a lot of apps were like updated decades ago. So there is no recency check. Also, we need to aware consumers about safe use of apps. Okay, so how many of you use some kind of health app? Oh, good. Do you know that there are safety concerns? No. So we need to educate consumers about what app to use, what not to use, how to use, stuff like that. So this is also an important recommendation. These are the people I'm super grateful for. Yeah, Doc, I've got a health app. How about you examine my phone while I wait in the pub? This is coming soon, yeah? We do so much afterwards now. Okay, that's it. Questions or comments? Sure. Yeah.
So what do you propose as next steps to address some of those?
Okay, that's a really good question. And we talked about it. I in fact had a chance to talk to Faye about it too, that we can like take this research up and maybe look at what particular apps are more threatening, like what groups of apps should be more focused on. But in terms of regulation or policy making, the apps that we use as consumers, we can start by looking at that particular app. So we can look at the reviews, we can look at how that app is built, we can look for the medical professional there. This is how we begin as consumer. And then as a health informatician, we can go about, and if you are involved, I know that a lot of people at UNC are working on various app development. So we can look at the app that we are developing or our teams are developing has enough professional involvement and the information is evident in science, is proven. That's another thing. Also, what we can do as consumers is not to trust on the app like 100%. If you remember the slide that talked about consequences, there was this hazardous event that said there's a chance, and studies reported it, that there's a chance that people would stop going to the physician and would depend on apps. It is good in a way that it helps the hospitals and administration, but it's also important as a consumer to look at things from all the areas. So yeah.
So you're relying on consumers.
That's
relying on the girl from Kenya. Oh, okay.
Oh yeah. So that's like another thing. So consumers is one thing, and then there is a huge responsibility on the regulators, the policymakers. So for example, FDA. Recently, I think last month there was this report from FDA that they might take up the regulation of mobile health apps, but they have still not given certain guidelines. So they do have bulleted paper that talks about medical devices and stuff, but there is no clear guidelines for all other kinds of apps. So maybe that would be the first step for regulation, because we need somebody to look at what's happening. For example, in healthcare standards, we have GSCIA and we have ISO and stuff like that. We look at things, right? We look at how hospitals are working. They give you standards, but for apps that is almost doing what healthcare is doing these days, there are no standards. So yeah, building those standards, those frameworks, maybe taking the responsibility of app as the developers is important here. Does that answer your question?
It does, yeah. I mean,
yeah, sure.
From your demographics that you collected, did you find that there were groups of people that were more or less likely to use apps or multiple apps? Or
yeah, that's an interesting question. We didn't do that, but yeah, that could be seen. What we did is we looked at the age group that was more into apps, and we looked at the number of apps that we're using. So we thought that at this stage and within this scope, we didn't really do that, but that's a good idea. That could tell us like a lot of things about people's behavior towards technology. Yeah.
Saba, very interesting work. I was at a meeting recently where we were talking about locally at UNC, people are beginning to talk about how do we get a handle on what FDA is doing terms of its regulations of the whole range of things, not just apps, but starting with devices, and there's this gray zone of software that are not necessarily apps that may reside on obviously computers serving medical purposes, and then you have apps, right? There's a whole range of computerized sort of healthcare support and tools and technologies, right? Did you come across anything that even hints at FDA developing maybe a registry or some type of even a simple website with sanctioned, scrutinized, reviewed, approved at different stages of FDA that it does with drugs? Is there any information where it's beginning to kind of publicly share what types of things that it has reviewed?
Yeah, that's a very interesting question. So like I said, last month they issued this report where they talked about how their plans are to go from medical devices to wellness devices. Last year they had this blueprint about how they do it with medical devices. So I read a paper where it says, okay, medical devices are regulated according to this criteria.
Right.
But it's just for medical devices.
That's right.
And it's not for all other kinds of. But it's in their plan. But that would be really ideal if they could take over the entire range of.
Yeah, I think the line between a device, a software, and an app is like becoming
and you never know, tomorrow there'll be a new thing. And there's no full stop to this range.
That could also be beneficial to the app developers if there's some kind of a certification of excellence or whatever it is, process that they go through. That's a huge leg up on competition. That's not going to. These are worldwide, so that certainly could be a standard of excellence that they could meet.
The other thing I was going to ask is, because your research is also based outside US in Australia, is there something equivalent to FDA? Yeah, I'm sure it's in Australia. Are they doing anything in this area?
So some of the respondents said that they contacted national authority. So it's called, they have three kind of national authorities. One of them deals with all kind of health technology. The other deals with digital health technologies. It's called Australian Digital Health Association. And then they also have links to JCIA. So one of them said we wrote to JCIA as we use it for disease and stuff. So yeah, there are people there who are regulating it. But again, I think the extent of regulation is very similar to what is here. And the number of apps that are coming from the US is way more than those that are developed there. So that also makes a difference because they're developed here, but they're used everywhere.
Yeah, the big challenge here and FDA that unfortunately that we keep hearing, and then also in other countries, is lack of resources. And it begins to kind of corrode, reviews, making sure that things that are being used by people for making crucial health decisions are safe. And
especially in developing countries.
Yeah.
Like I know that from my home country, and the people are working on app development.
Right.
But we rely on FDA. We don't have any watching them.
That's kind of dangerous.
That is, it's the same with a lot of countries.
Yeah.
So I think one of the challenges is that if we are only looking to the FDA, then we only get their perspective and the way that they always conducted regulation. And in all honesty, I think that there's going to be a technology lag, there's an innovation lag. I'm intrigued by this idea about consumer grassroots approach, right? So I think one of the questions to ask next participants in a survey is how do you make decisions about what app you put on your phone of any kind, right? So I go to a Google store, I see the rating,
Yeah.
I look at the rating. If it hasn't been rated, I don't even, like, it's not going on my phone for all kinds of reasons. So I'm wondering if maybe a speedy mechanism in which to start to draw attention is collaborative work with how things are rated, and that, you know, an approach to someone like a Google store with this is the standard for when there's a health app. And we might say that an intermediate app should disclose this app is developed with physicians and nurses or bioscientists. And then there's a method for reporting to that app, because that's what I wrote. Who's the reporting authority? In the United States, if my cardio trainer, which is the one app I use all the time, if it died or miscounted my steps, I would have no idea who to send that information to. So some countries will have a mechanism, and then other countries will have. So
yeah, these are really interesting parts. So there was this one study that wasn't included in the final review, but that actually studied the Google app reviews, like the number of stars and everything, with the actual app quality. And I found out that even if the app has 5 stars, doesn't mean the app.
Right.
So it's like very big.
Well, and I think the triggers, like if you go in and go ahead and rate a couple and you see the things that they ask.
Yeah.
So it may be that what gets asked in a health app
Yeah.
are things that are very targeted towards capturing where it's not safe. It's usability.
Yeah. Yeah.
Yeah, well, mostly they ask for usability.
Yeah.
And I'll give it 0 stars if it makes my phone bomb. You know, if my phone is rebooting every 10 minutes, then it's out, then it gets good stars.
Yeah.
So,
Last week, no, 2 weeks back, we had this session where we talked, when people from Veteran Health came to UNC and they showed us about the escape app that they're working on. And they developed it with physicians at UNC hospital. So I think that's also a good way to, when you talk about whom to report. So when you use that app, it has a UNC logo on it. So you know that somebody is taking the ownership of it. And if it does something wrong to you, you know whom to contact.
Right.
So I think that organizational ownership can also be helpful.
Sure. I think involvement of healthcare providers is very important. Very important. Either, as you mentioned, in the view of patients, from medical point of view, and also in patient education sessions, maybe increase awareness of the patient that they never rely on diagnosis of dangerous disease like melanoma or HIV by application. I mean, it's not a sort of telehealth tools. It's completely different. It's not reviewed or monitored by physician. So, increased patient awareness is very important through healthcare providers.
Yeah, it's so important because the app that I was talking about, that the UNC is creating, they only let their patients access it, like with their login ID and password, once they have counseled them about the app already. So otherwise, not use it. So I think it's a good idea. Most of the physicians I know, they don't opt for app, but they do not discourage the app at the same time. They're like, okay, I don't agree with the app. But instead of just saying that I don't agree, it's important to tell the patient that you should not rely on this app. It's like, because that's very
I
important.
definitely think that providers struggle with ways to counsel their patients on anything that is available through the internet or mobile devices. Consistently, I would challenge you to go to your provider and say, if I need to educate myself, where do I go on the web? And maybe they would say, Mayo Clinic. I use Mayo Clinic. I use WebMD to hear it in English, and then I use Mayo Clinic to understand it, as a scientist. But I don't think that clinicians are well prepared, and I think that they should be. They should be. This is the age. People want to be autonomous in their healthcare. They don't necessarily only want to rely on someone. They want to be well informed even before they get in the door. They want to be well informed, and so, that also means that you have to have a degree of awareness about apps and,
Yeah.
Saba, I was gonna ask you a question about the data that you showed, like 21% of those that's answered said that something like literature was providers were linked to apps. I'm trying to remember the number. Go back a few slides.
To the review?
Yeah, to further back.
Okay.
Right there. Lack of medical professional involvement, studies. So this was just from the studies review.
Yeah,
Okay.
so 1% of the studies reported.
Right.
These were the studies that were reviewing different apps.
Right.
So they said these apps have no medical professional.
That's a little hard to sort of interpret because you're saying among those that you reviewed, 21% of them reported.
Yeah.
Only 21% reported lack of medical professional involvement in the process of app development.
Yeah.
That I think that aspect though of lack of linkage of app to providers is a big deal. It's a very critical issue.
Yeah.
Right.
So let me just make sure I understand. So what to me, what this is saying is that no one brought physicians to the table when we put the app together.
No, I think what this is saying is a little different. It's saying that among the studies that they reviewed, only 21% of those studies really address this issue, right?
Yeah, so they had this
So,
in writing,
right,
that the apps that we are reviewing
right,
do not have medical professional involvement.
right. But that doesn't mean,
That
I would
was
think
another
like,
aspect,
yeah, I think actually
Yeah.
99% of the
Oh,
apps
truly,
don't
yeah,
have providers linked.
But these are the
Oh,
the
so of
studies
the
that actually talk about
published
it.
studies,
Yeah.
20
Yeah.
targeted this as a measure,
Yes.
an evaluation measure.
Yeah.
Right, yeah, that is
It was
false.
brought
I assume, I was like, wow, 90% of apps.
So,
Yeah.
yeah, but I think broadly though, that issue of lack of provider sanction or provider scrutiny or even a linkage to a provider of these apps. So apps sort of are in their own realm,
Yeah,
existing on their own,
right.
is a huge issue. It's a very big issue. What's surprising, I think, is, I didn't see a stat on abandonment, which is very well known, that after a few months, essentially, people abandon their apps. Most people do. They don't continue using the apps anymore.
Yeah, we can look at that. After we just asked respondents if they still continued using the app.
But I think that's where the provider linkage
Yeah.
plays a critical role.
And do you think that prevents the reasons we have so many new apps coming up? Because
Yeah, I think so, and I think people have to completely. No, people that design these apps are really, I wouldn't say they're not knowledgeable or aware. They don't sufficiently appreciate how healthcare works. And especially in this country, if you don't link things to your provider, you might as well not, serve it. And tell me a name of an app that really took off and has become like that killer app in healthcare. There are very, very few. It's extremely rare to find apps that actually have made a name for themselves being successful, right? Because of this reason.
There's no relationship.
To the provider, it doesn't close the loop.
That's a huge dissatisfaction with people with COVID, is that there's still not a way to link. And I do have to say though, providers also have to welcome the information. And currently they do not. So even if you use your Epic, which is the predominant electronic health record, and you upload data, your whatever daily finger stick, your daily weight, my experience and the literature will support that physicians in particular are suspect, right? Because if I'm measuring you on how well you're managing your glucose, will you cheat patient and not put the honest figure in the portal so that I can be monitoring frequently? So there's still, patient collected data is still a bit suspect when the provider.
There's this interesting app that I came across when doing this, and it's about medication management. So like you have to show the app that you are actually taking the medicine, and so you have to click, and it would measure the signal, and it's like, okay, now it's checked.
Yeah, so you turn around and spit it in the trash. Yeah, so what are we accomplishing
They'll do it
here?
when they do. Yeah.
Boy, that feels intrusive. Oh my goodness.
Yeah, fascinating work. I don't do apps, I do web-based mobile health interventions. So what I'm seeing here is kind of astounding. And follow Jarvis' comment. And I didn't see the small words, and the study reported is like the percentage. But even with that, it's quite shocking because look at the lack of scientific evidence, look at the errors, and I wonder about I'm from nursing school, so we have malpractice, right? How about the right accountability? Lawsuit related to that. And another thing that I don't even know how to say it, because in our area of research, we talk about the dissemination, implementation. There's a lot of evidence in research, but mostly in-person intervention, clinical practice evidence. And it should be, I'm very surprised that 38% reported there's a lack of evidence. It seems there's a disconnection between the scientific community and also the provider, just like the other one says, and also the needs. Do you see what I'm talking about? So how to bring these two groups together, and also there's a national trend about implementation, dissemination, how to bring them together and then create something more reliable.
Yeah, that's very important because publication bias is a real thing. People don't really talk about negative stuff. They don't even want to write about that went wrong. So out of these many studies, only a handful talk about adverse event. Not everybody would want to write about it, but it doesn't mean that that doesn't happen. So yeah, there is a gap between academia and industry, providers and consumers.
Eager to read more on this topic again, because the mobile health, I think we face similar challenges. And on the side, how about, did you read anything about the cognitive function one, luminosity? Is that the app? Is that luminosity?
Oh, luminosity.
Yeah, it's part of this. I was very curious about the report of that
I
program.
don't think any study that we reviewed actually studied luminosity.
That's interesting, because that's evidence-based, and it's
That is evidence-based. Yeah. I think their web-based design came first, right?
Yes, but now they have apps.
They have apps right now. Yeah, but nobody studied that. That's interesting. I think a lot of people do not know the name of apps.
That's another thing,
Yeah.
The pattern, I don't know whether it's a pattern or something else.
So I just want to clarify the data that we're looking at here. So if I reviewed 100 published reports, 38 focused on the scientific evidence, 32. Okay. So I wonder if.
So just
right. I want to make sure I understand.
Not necessarily 38%. So say 100%, 100 studies reviewed absence on that. Okay. Now, I reviewed, for example, 48 studies, and out of them, 38% actually reported that there is no scientific evidence. There could be studies that say there is scientific evidence.
Right.
Okay, so this is just those that said these
So
are
it's
the
just
complete
a count.
numbers.
So
Yeah.
I guess what might be interesting is then to create an N of how many apps were
Yeah.
reviewed.
So when Dr. Javi was talking, I was thinking the same. We could do an
Right, because that's
number of
confusing. I was like, oh,
apps
look, a
yeah.
third, that means that
Yeah.
60% do have, but
You
that's
see,
not the case.
these are N, because in percentage, they would give a false image.
Yeah.
So these are number. of
Those are the
apps.
actual
Yeah,
counts.
yeah, number of steps.
Yeah,
Yeah,
okay.
yeah. But yeah, that's good. Good idea. So yeah.
It's
Thank you
really
very
fabulous that you went all the way to Australia.
Oh yeah.
I just think that's
And you're our first international NHI student.
spectacular, right?
Yeah. So it wouldn't have been possible without these maternity.
What's the next step? Where are you going?
I'm going there. Yeah, I've
Gonna work?
So I went there during the spring break and presented the same thing there and talked about space. They have these really interesting PhD opportunities and we talked about that space. So yeah, it's the negotiation.
Good. That's exactly what I was there when you were presenting. I was like, I wonder if PhD is coming.
I really want to do PhD someday. And these are mainly people, so.
That's good.
Thank you guys.
Well, excellent. Thank you so much.
Oh, this is the Nati. Just FYI.
Which one is team? Which one is Farah?
The one in skirt?
She was great. She was so good to
Oh,
work
she
with.
is. She's
Yes, very responsive and great.
So this is the patient safety.